Thank you so much for joining our session today. So as per the poster, we are going to focus on coagulopathies and bleeding disorders. These are complications that arise as a result of failure of your blood to clot appropriately. And we realize that clotting is a normal protective mechanism that protects your body from getting infections or even losing excessive blood that might risk your well-being as an individual. And as we can relate from the previous session that we've held, we had a session on hypertension and heart failure. And with these conditions, we realized that heart failure was could come as a result of coagulation problems in the blood, where you have a clot being formed and impeding access to nourishment of the heart, but that will lead now to heart failure. So there are different issues that can cause these coagulopathies and bleeding disorders. And these are some of the things that we are going to look into. These are some of the things that we're going to discuss in this session and realize that in the outset of COVID-19, we have to look out for our patients. We have to ensure they're well protected from getting the infection because there is a risk of developing coagulopathies because of the disease, especially for the patients who have severe complications as a result of these complications. So to start us off, we look at coagulopathies. As I mentioned, they're a group of disorders characterized by impaired ability of blood to clot. So it can result with one, either you have excessive bleeding in certain cases or increased tendency of blood to clot even in circulation. So being blood is responsible for nourishment of your body. Failure of your blood to flow, failure of blood to move and all that, a clot being formed, it impedes the movement. It's like your blood system, the blood vessels are pipes that are transmitting the blood. If they are blocked because of the clots that are formed, it means your organs will not have access to the nourishment that they need, the oxygenation and all that. That will increase the risk of someone having a fatal outcome of that condition. So it can be associated with excessive bleeding in certain cases or an increased tendency of blood to clot even in circulation. And the clotting process is controlled by two mechanisms. That is one, the blood factors, the number of protein factors which are produced by the liver. And another thing that also is responsible for blood clotting is the blood component platelets. And so there's a standard number of platelet cell fragments that we need in our body for normal bleeding, which is normally between 200 billion to 300 billion per liter of blood. And then blood clotting as a process means we have the factors in place, the platelets and other minerals. For example, vitamin K is required. Calcium is very essential in that case. So we need to know that the blood clotting is initiated through two pathways. The intrinsic pathway, which comes as a result of interaction of platelets with negatively charged bodies, and then the extrinsic pathway, where there's tissue injury and the exposure of tissue fragments into the factor. So these are things that can lead to either failure or inability of blood to clot when it's supposed to be clotting. Then now we look into the clotting cascade, which as per the two pathways that I mentioned, the intrinsic pathway and extrinsic pathway, we have tissue factors that are responsible for the clot formation. So these factors, once activated for one after the other, the activated form will activate the subsequent one, and that moves to the common pathway. There we have the X, the Roman number, then factor X, which is also known as the Stuart power factor. The Stuart factor is responsible for conversion of prothrombin factor 2 to thrombin. Then thrombin, upon activation, will activate now, convert fibrinogen to fibrin, which is the clot that is being formed as a protective mechanism. So those are some of the critical things. Then as per the clotting cascade you're looking at, we have the prothrombin time, which is a measure of the ability of your blood to clot in a normal sequence. So normally the ability of blood to clot when exposed to the outside environment takes between 30 seconds to 1 minute. If you have a tissue injury, maybe a cut to your hand, a cut to your leg, or something of the kind. So it will take 30 seconds to 1 minute for blood to clot. In other circumstances, when you have a coagulation problem, some people might have a prolonged prothrombin time. It takes longer for these people to have their blood clot. And for the intrinsic pathways, normally localized within the blood vessels. And there is a problem that can result when you're not able to clot or when the clotting rate is higher. For example, in an injury in the blood vessels, this can lead to clotting problems when we have. So there's a normal process that we want for it to protect you from excessive blood loss, for it to protect you from infection when there's a cut on your body, and also to facilitate healing of your body. But if that doesn't happen, then we have a problem that needs to be addressed. Then additionally, now to the next phase, we have the breakdown of that clot. Once a clot has been formed, it has to be broken. So the breakdown starts from the TPA, the tissue plasminogen activator, responsible for conversion of plasminogen to plasmin. Then plasmin, when activated, now will act on fibrin, the clot that is formed, to break it down to the degradation components. And as a relation to the COVID-19 that we're having at this point, COVID-19, there's been the people who have severe complications who are manifesting with coagulopathies, bleeding disorders, or clotting disorders in short, they're having an increased level of D-dimers. And D-dimers are protein fragments of blood clots that have been broken down. So once you have the products of degradation high in the circulation, then you realize it means there was a formation of these factors, these clots, and the clots have been broken down. So it means people with COVID have manifested with increased risk of coagulation and increased risk of coagulopathies. And as per evidence that is coming up, we're seeing that it's being classified as disseminated intravascular coagulation, where it's induced either by autoimmune processes, the body trying to fight an infection, and in the process of fighting infection, it activates the coagulation pathway, as I mentioned here on the initial slide that we have here. So these are some of the things that we have to realize that are being pointers, and that's why we need to take extra precautionary measures for people who have coagulopathies or people who are at risk. And that's why we have this session. Then the other causes of coagulopathy now we can look at it as thrombocytopenia, which is lower than the normal platelet counts. As I mentioned, we have 200 to 350 billion platelets per liter of blood. So in certain situations, the levels are lower, which when it's lower than 150, we are considered someone to be thrombocytopenic. But then spontaneous bleeding can start at around 30 billion platelets, which is a less level that would be required. So it means low level of platelets might be a risk, but it's not that much of a risk up to a point when it's very critical. And it can be a result of a reduced production or increased destruction. Reduced production comes as a bout of pancytopenia that can be failure of the bone marrow to produce blood cells. Increased destruction, spleen is overworking to kill them, or there's an infection that is making your body to react to at a higher rate, killing the platelets that are there, destroying them. Then vitamin K deficiency, vitamin K is responsible for activation of the different clotting factors, as I mentioned earlier, which are produced by the liver. So when vitamin K is not available, activation of the protein factors are not possible, then this will lead to coagulopathies and bleeding disorders. And those are some of the things that we need to look at. So when we're looking at vitamin K deficiency, it can be as a result of impaired absorption, meaning you're not able to absorb vitamins the right way. And being it's soluble in fat, it's a fat-soluble vitamin, it will be asked to take fatty foods to improve the absorption and some kind of the kind. Then hemorrhagic disease of newborns also can lead to vitamin K deficiency, especially that occurs because newborns have lesser of the bacterial colonies in the GIT. Vitamin K is also produced by intestinal bacteria. So when the bacteria are not developed in kids, then it means they might not be able to produce vitamin K. They have a deficiency, and that predisposes them to bleeding disorders. Then we have dietary deficiency, you're not eating enough of it, you're encouraged to eat leafy vegetables. Then we have disseminated intravascular coagulation. Coagulation system is activated within the blood vessel, and that is an alarming concern that we need to look into. And it's one of the things that has been implicated in the current COVID-19 situation that is leading to hypercoagulable state, and people are having severe complications. Some of the other causes can be congenital disorders, which are genetic, they're inherited from one generation to the next. Most critical ones are hemophilia A, which is also sex-linked, and hemophilia B. And then we have the von Willebrand's disease. This is another condition that we have to address and look into as much. However, it's not as severe, so not much attention is being given to it. For the risk factors, we have genetic factors for the congenital decisions that I made, the diseases that I've just mentioned, hemophilia A, B, and the von Willebrand's disease. Then we have liver failure. Clotting factors are produced by the liver. So when the liver is not able to function optimally, then it will lead to the coagulopathies that we're talking about. Then we have pregnancy and elevated level of clotting factors and probable acute fatty liver disease and gestational thrombocytopenia. So in case of pregnancy, the clotting factors are produced at a higher level. When they are in higher levels in circulation, then it means your chances of blood clotting are also high. Then another problem we have, there's a chance of acute fatty liver disease or gestational thrombocytopenia with pregnancy, reduced production of platelets, or liver disease, reduced production of the clotting factors, that leads to and risk of coagulopathies. Hormonal contraceptives that have been in use in the market are estrogen and progesterone combination or plain products. They increase the clotting factors and lower the antithrombin 3, which is responsible for protecting you from clot formation. Because as the chart we looked at, prothrombin being converted to thrombin. Now for the thrombin activating fibrinogen to fibrin, antithrombin 3 is responsible for inhibiting the conversion of fibrinogen to fibrin. So clot formation doesn't happen, but it is lowered. So when it's lowered, it means chances of clotting is higher, and then it means your risk of coagulopathies are also heightened. Surgery or tissue injury, these surgeries and tissue injury, surgery can lead to tissue injury as well. So it exposes you to thromboplastin, the tissue factor that is activates the extrinsic pathway of blood coagulation. So there'll be higher risk of clotting. Infections such as infective endocarditis, that leads to septicemic intravascular coagulation. It's also one of the disseminated intravascular coagulation processes that we have to look at as well. Then prolonged bed rest, lack of activity can increase your risk of having blood clot. So when blood is not moving, chances of it clotting are high. And that is why we'll have the virtuous triad, which looks at the probable contributing three very critical factors that leads to heightened risk of coagulation. That is reduced movement, lack of activity, or prolonged bed rest. So that's why even patients who are hospitalized in the hospital, they normally have heparin injections to protect them as prophylaxis from them not having coagulopathies. Another thing is the coagulation factors availability, and then tissue injury. So they have three key factors: tissue injury, prolonged bed rest, and coagulation factors available. When the coagulation factors are heightened, risk of clotting are also heightened. Then the complications that come, we have DVT, deep vein thrombosis, and venous thromboembolism. These ones are as a result of clot being formed within the deep veins. It majorly affects the lower limbs, the foot that is. So when that happens, the most critical complication that arises is when that now the thrombi, the clot that has been formed, is dislodged from where it was formed and it's moving in the circulation. It can get to your head, your brain that is, and that can lead to cerebral infarction or stroke, which can lead to death. Myocardial infarction, a heart attack, if it blocks any of the coronary arteries or the coronary veins, it can lead to a heart attack and also death in some situations. Pulmonary embolism, the clot that has been released gets stuck in the pulmonary artery from the heart into the lungs for oxygenation of that oxygen. Then it will prevent blood reaching the lungs, meaning there will be failure of the lung to get nourishment as is required, and this can lead to death. And that is the most critical complication of deep vein thrombosis, especially in pregnant women, and that is something that needs to be looked out to. Then other complication can be people not being able to have their blood clotting, especially in hemophilia. Excessive bleeding can lead to hypotension, low blood pressure because of the low blood volume in circulation, and death can result from this. Those are the major complications that we have with coagulopathies and bleeding disorders. Then we'll have the coagulopathies and COVID-19. In COVID-19, there's been reported increased hypercoagulable state. So it means there's a chance that we have higher clotting factors in circulation. And with higher clotting factors, the chances of clot formation within circulation, disseminated intravascular coagulation is higher. Then when the clots are being formed, they have to be broken down, the fibrinolytic pathway. So when they're broken down, we have elevated levels of the products of that breakdown. And that is where we have the D-dimer elevated in some of these patients and a prolonged prothrombin time. The prothrombin time is the time it takes for clot to form. So it will be prolonged because most of the clotting factors are in the coagulable state. They have been formed a clot and that clot is broken down, so they're not available to facilitate other clotting. So that is going to affect the treatment of this kind of people. And we have to be very critical and ensure that we try as much as possible for people who have coagulopathies not to get infected with COVID-19. If they get infected, we need to ensure we initiate prophylactic measures, especially when they're hospitalized, where there's limited movement, one of the risk factors for coagulopathies, and where they're being managed to ensure they don't move to severe or critical situations when we can protect them from getting to that. Then in terms of management of coagulopathies, we encourage first lifestyle modification. Reducing intake of alcohol. Alcohol can lead to fatty liver disease and any other infections that affect the liver, for example, hepatitis and all that. We have to adjust our lifestyle. Reducing intake alcohol, drug injection, those are for the people, drug addicts and all that. We have to reduce that. Smoking needs to be reduced. We have to maintain an active lifestyle to ensure that our body is actively pumping blood and our heart function is optimal, so that we don't have a stasis, a point where the blood is not moving at a particular organ that increases the chances of clot formation. Then after the lifestyle modification, we have the pharmacological. This is where now we encourage the use of medicines. In use of medicines, anticoagulants prevent clot formation. And there we have the ones that are injected: heparin, lepirudin, bivalirudin, agatroban, danoparoid, and drotrecogin alpha. Those are the injectable ones. Then we have the oral ones, warfarin and rivaroxaban. So most of the ones that are being recommended majorly that people have been using are the oral ones. The injectable are limited, but they have been used in prophylactic management, especially people who are critically. For example, heparin, the low molecular weight one, has been used in a number of cases. Then we have the fibrinolytics. In case someone has clot formation within their circulation, the clot needs to be broken down. For example, when we have pulmonary embolism, thrombi, deep vein thrombosis, the fibrinolytics such as streptokinase, alteplase, rotoplas will be used to break down that clot. And that is one of the things that we're looking at. Then antifibrinolytics, aminocaproic acid, the major one has been tranexamic acid. And tranexamic acid has been used to prevent clot formation, to prevent clot formation in circulation, and also enable people to respond in a positive way. Especially tranexamic acid is the one that we normally use for people who have epistaxis, that is nose bleeding. So they have to be given such products to enhance their ability of the blood to clot. The antiplatelets, those are kind of rescue drugs: aspirin, clopidogrel, clopidine, and all that. Especially aspirin is the most recommended one, 75 milligrams, or clopidogrel, and they protect you from clot formation, which is activated by a certain pathway. It's called the cyclooxygenase pathway. So these drugs are being used in management of coagulopathies. However, critical thing to note, these drugs, when they're being used, it's recommended that this use is being guided by a medical doctor, and that medical doctor should be competent, qualified, and should monitor certain parameters, for example, the prothrombin time. And then the administration of the drugs, the choice of drugs and issuing has to be by a pharmacist or a pharmaceutical technologist who is qualified to monitor that care. Nobody should buy these drugs from over the counter, and they should not even be sold over the counter unless there's a prescription that is based on a clinical judgment. So that is very critical in terms of management of coagulopathies. The next steps as we finish up on this section: infection prevention and control. We have to reduce the risk of infection with COVID-19 at this point in time, and any other infection that might be there. So we need to adopt the infection prevention and control measures that are in place. Physical activity, we need to avoid the risk factors of getting coagulopathies. So maintain physical activity, lifestyle modification, avoid alcohol intake, dietary adjustment, leafy vegetables, green leafy vegetables to improve your vitamin K levels. Prophylactic management of at-risk groups, pregnant women who are hospitalized, people who have been hospitalized for more than 4 days, they need to start getting the rescue prophylactic doses of heparin so that they don't get coagulopathies. Then we have controlled use of hormonal contraceptives, especially those are high in estrogen. We need to control the use of them. But however, there are developments that have been placed, and most of the hormonal contraceptives have lower levels of estrogen, which increases the risk of developing these coagulopathies. Those who are being managed, compliance with medication, very critical. If you comply with your medicines, you are at a better position to improve from this condition, not get a crisis, not get to the severe fatal states that we are seeing with some of the cases. Then we have to ensure patient engagement by medical practitioners in care. We need to keep engaging every other time to ensure that our patients get the best care, they get managed optimally, and we ensure that they don't get to the critical phase that might arise, and patient needs to be informed. Once they're educated, they know what to do, when to do it, and how to keep following up on their management to ensure we attain optimal treatment outcomes. And that marks the end of my presentation for today. Thank you so much for joining in. It's been a pleasure, and I hope we get to learn again next week. Thank you so much.